pick up on a change in exam in half an hour rather than 3 hours, that makes a big difference in terms of how much we are able to recover in terms of that patient's function. So, a couple of common procedures in vascular surgery that I think might be done at West in the near future. This, of course, doesn't cover lots of other things that we might be doing, but carotid endarterectomies are already happening here, and expect to do more of those. Lower extremity bypasses, I don't think that we have done many, if any, here yet, but I expect that that will happen within the next year. Lower extremity angiograms, there are a lot already happening by the cardiologists and interventional radiologists, and I think as vascular surgery, we're just starting to do some of those procedures here. And lower extremity amputations, unfortunately, is also part of our practice, and I'm sure will be happening here. Dialysis access surgery, we also do a lot of here. You probably won't see much of that in terms of post-operative patients in the admitted setting, but a lot of patients who are on dialysis and have fistula and grafts, you'll see. And so if you have any questions about how to identify problems with those access sites or things like that, then I'm happy to talk about that later. So I'm going to focus today on just two major vascular conditions: carotid artery stenosis and lower extremity peripheral artery disease. And the first of those is carotid disease. So why do we care about carotid artery disease? I think if you ask many surgeons, you'll see something like this. You know, we care because there's ugly junk inside arteries, and that's nasty looking, but I would argue that that is not why I care about carotid artery disease. I care about carotid artery disease because it can cause stroke. So in general, in vascular disease, again, come back to that history is so important. Someone who has really ugly looking CAT scan or really ugly looking duplex or artery bothers me a lot less than somebody who has symptoms. And so somebody who has had a stroke is someone who is at much higher risk of further stroke, much higher need for intervention in most cases, and in the preventative setting, the reason we do it, we do any carotid interventions is to prevent stroke. That may be confusing sometimes. You see what, this person's got a 70% blockage, why aren't we doing anything? And patients get concerned about this, and really this all comes down to thinking about, well, do we think that this is likely to cause a stroke, and can we make that better with something that we do? Because all of the interventions that we think about for carotid disease, whether it's stenting or transcervical stenting, stenting from the groin, endarterectomies, all of these things have a risk of causing stroke. So that's the big question for us, is figuring out what is going to reduce the chance of stroke. And I have here a nice picture from the American Heart Association of the classic symptoms of stroke. There's one symptom up here that is a symptom of carotid disease that is not a symptom of stroke. Does anybody know what that is? This is a good medical student question. What's the first branch of the internal carotid artery? And they all think about all these branches in the face or branches in the brain, but actually the first branch from the internal carotid artery goes to the eye, the ophthalmic artery. And so patients who suddenly lose vision in one eye, the fancy name is amaurosis fugax, I don't actually know how to pronounce that, or transient monocular blindness is because a little piece broke off of the carotid artery, went to that artery to the eye, and it's basically like a TIA of the eye. And so that's not a stroke, it's not happening in the brain, but it is the same process that if that little piece had, instead of going to the eye, had gone to the brain, would have been a stroke. So that's one thing that's missing from this, but I always ask patients about for carotid disease. Okay, so causes of carotid artery disease are, this will will be a common theme whenever you think about any peripheral artery disease, really. Hypertension is both a cause of stroke, can cause bleeding in the brain and things like that, but it also separately can cause stenosis in the carotid arteries. Problems with lipids can lead to plaque in the carotid arteries, just like many other arteries, like the arteries in the heart. Diabetes is related. Age, of course, is a contributing factor for developing all these atherosclerotic diseases. Smoking is the big contributor, probably for most patients. And I put atherosclerosis here as a separate thing, although really all of these are mediated through developing atherosclerosis, through developing plaque in the arteries. And so knowing each of these sort of related conditions for carotid artery disease suggests all of the preventative care that we can be working on. So whether perioperatively, preoperatively, postoperatively, all of these are all reasonable times to intervene for all of these conditions. So for hypertension, blood pressure control in the long term is important just for developing of atherosclerosis. In the perioperative setting, I would argue it's even more important. So high blood pressure when you have just reopened an artery to this side of the brain that has not seen that much blood in a long time is a risk for what's called reperfusion edema, or it can be reperfusion syndrome of that side of the brain. And this, in the worst case, can lead to bleeding in the brain, either stroke or subarachnoid hemorrhage or other bleeding. And so, especially in that immediate postoperative period, I always recommend that patients have really tight blood pressure control. And you might hear slightly different numbers from different people, but somewhere in the range of systolic blood pressure of 90 to maybe 160, but not out of that. And many would argue for a tighter control than that. And I personally feel like that should be something that is monitored very closely, instead of, many patients, they might have a blood pressure of 170 and you give them a dose of hydralazine and you wait a couple hours and you see if they're okay. In these patients, I tend to think that they should, we should have a low threshold to put them on an infusion or to check 10 minutes later or something, because even short periods of hypertension can lead to problems. We had a patient at Methodist who had a subarachnoid hemorrhage recently. She had blood pressure controlled all night, wasn't needing, maybe she had one dose of an antihypertensive, but she was basically controlled all night, and then was getting ready to go home the next day. Her systolic blood pressure went up to 197, wasn't immediately controlled. She developed a severe headache, had a subarachnoid hemorrhage, and she ended up doing well. We got it controlled and it didn't cause any further complications, but had we been even more on top of that blood pressure, I would hope that we could have prevented that. The other thing to say about tight blood pressure control is that that complication doesn't usually happen like that patient post-operative day 1 in the ICU. It actually typically happens 3 or 4 days after surgery, when the patient's already gone home. And so even if the patient's blood pressure seems pretty good for you, what I really care about is that they go home and stay controlled at home. And so if you found that a patient was needing multiple rounds of IV interventions to control their blood pressure, and then we said they should probably be going home, that would be someone that I would want to know from you, we're having to get, that they're not controlled on their outpatient medications. They're only controlled because I was giving it these PRNs that you ordered. And personally, I would rather keep that person another day, make sure that they're controlled off of any, off of the sort of care that they wouldn't get at home, so that when they go home, they're controlled. Cholesterol, there's good evidence for, again, most vascular surgery procedures that statins are beneficial in lots of ways, not just for keeping lipids at a normal number, but for controlling the, what they call pleiotropic effects on the plaque. That they're less likely to have plaque ruptures, less likely to have other thromboses, events that can cause complications in all these different vascular procedures. And so, as a general rule, whatever other medications might be held before surgery or after surgery, I always want statins to continue. There's evidence for a lot of these procedures that even if someone wasn't on a statin before, giving them a dose of a statin the day before surgery has some benefit. So, it seems surprising, you'd think that these are things that happen over a long period, but even those single doses around surgery can be helpful. Diabetes suggests that we should, control blood glucose well. I think there's probably, that is probably per your standard protocol. I don't think there's anything in particular about that related to carotid artery disease perioperatively. Age, I don't know that we can do a lot to prevent. Smoking is, again, probably the biggest factor for all these patients in developing all of their cardiovascular comorbidities. And so whatever you can do to help encourage these people to stop smoking, cut down on smoking, accept a patch or a medication or whatever, who knows which patient might respond to you differently than they would to me. And I talk about it with every patient in the office, but sometimes they're willing to think about an intervention for smoking when they just had a surgery. And so, maybe when they see this potentially bad consequence of having, a big surgery, maybe that's a time when they'll be open to stopping smoking. So I'd appreciate anything you can do about that. And then atherosclerosis. So antiplatelet medications in general, we recommend continuing through surgery, in contrast to lots of other types of surgery where people want to sort of, unless absolutely necessary for a cardiac stent or something, they want to stop all the antiplatelets, stop all the heparin, things like that. In general, we don't hold heparin before surgery, we don't hold aspirin before surgery, we don't hold Plavix before many of our surgeries. So when in doubt, I would continue all of those or ask if you're not sure. There are some of the newer antiplatelets like Brilinta, some of the surgeons want to hold that before surgery, or some lower risk procedures like doing a fistula, maybe we would hold Plavix but continue the aspirin. But as a general rule, our patients are at as high a risk of thrombosing things as they are at risk of bleeding, and we are looking at the blood vessels and pretty able to control bleeding in the operating room, but it's harder to control thrombosis. So we, as a general rule, continue all of those medications. Same for someone who's on a heparin infusion, not specific to carotid disease, but thinking about a vascular surgery patient going to the operating room who's on a heparin infusion. Usually that we continue pretty much up until they get to the operating room. Some people might say when they send to the operating room, or some people might just turn it off when they're in the operating room. But we usually like a little heparin more than we like a little less heparin.
What about oral anticoagulants?
So that's a good question. The question was, what about oral anticoagulants? And we actually just had a big discussion about this as a division. They had a sort of journal club discussing this because there were new recommendations from the preoperative clinic in terms of management timelines for oral anticoagulants. I think this is something of a moving target because the different oral anticoagulants are different in terms of their effects based on renal function and things. But as a general rule, we would hold those 2 days before surgery, and then whether or not to bridge them with some sort of, with Lovenox or heparin or something like that, would depend both on their sort of cardiac risk. Is this someone who's super high risk for stroke from their AFib and cardiology thinks they need to be bridged, but also for our patients, they've got a high risk bypass, and we're very worried that that's going to thrombose if we have them off heparin. Those people we would often bridge. But I don't, unless it's an emergency, we would not continue an oral anticoagulant. So, to the subject of sort of knowing baseline for carotid patients, I think this is probably something that you know well. The sort of evaluation for stroke, there are lots of different ways to do it. The Rankin score is one that is used commonly in some literature. It relates to how disabled the patient is. I don't think that this is used commonly in the hospital, but essentially is a ranking of whether they're having any symptoms at all, or if they're disabled, they're not able to function, things like that. Probably the score that you would see more commonly is the NIH stroke scale, and that's something that as a stroke center we're evaluated on, doing that pre and post any interventions, and so this should be something that's assessed in the before any carotid intervention, you know, in the clinic, or in the preoperative assessment area, and then after surgery before discharge. So I just put a couple of items here, but it is a more extensive list of going through, you know, upper extremity, lower extremity, motor, sensation, speech, gaze, all of these things. And yes, so knowing where they're starting from matters. If they're somebody who had a stroke and they came in with a baseline gaze problem or visual field deficit or something like that, we want to make sure we know that so we don't accidentally call a stroke code on somebody who's just having their normal symptoms. And then, of course, it's important to catch changes in symptoms early. As suggested by our friendly homunculus, the face and the hands are the things that are most likely to be affected by carotid disease. Of course, you can have lots of other symptoms of strokes, but the types of strokes that happen from embolization from the carotid arteries are much less likely to be something sort of vague or sort of non-specific, someone who's dizzy or someone who's confused or those sorts of things are much less likely to be a symptom of carotid stroke. And so, of course, you should do your full assessment of the NIH stroke scale when indicated, but in terms of just regular assessments, if they're moving their hands and they're moving their face, these are the things that I would assess more frequently. And the other specific thing I should mention is that facial droop is of course a symptom of stroke, but it can also be a symptom of having had carotid artery surgery, because there are cranial nerves involved and facial nerves involved in the area where we're doing this dissection. So I do most of my carotid surgeries under a regional anesthetic block, so they get a bunch of lidocaine or other local anesthetic to that area, or even if it was one of my partners who did the surgery with the patient asleep, they might still have given some lidocaine in the carotid bulb or something during the surgery, and so you can get some anesthesia of, say, the vagus nerve and have some hoarseness post-operatively. And so, again, knowing where they're starting from, if they came out of surgery with some hoarseness, that's good to know just immediately so that you know, it's not a change. But also some of these nerves you know, can be injured or manipulated during surgery, so they might have a tongue deviation or something like that that was related to the surgery. The other specific one that Dr. Gupta asked me to mention is the marginal mandibular nerve runs here along the jaw, and often in this surgery we're retracting up on the jaw, and so if that controls the movement of this side of the mouth. And so if someone were to have facial mouth droop on the same side as they just had surgery, that is almost certainly a sign of injury or a traction, irritation of that nerve, as opposed to having a droop on the other side of the face, which could be a symptom of stroke. So something to think about before potentially calling a stroke code or things like that. Of course, we would rather you be more sensitive than not to any potential stroke, but good to know those particular details. Some references in case you want to do some reading at home in preparation for your CMEs. Peripheral artery disease. Okay. Before I move on to peripheral artery disease, any other questions about carotid disease? Surgery, management?
Does vaping have anything to, like, does it have the same effects as smoking?
It's a good question. I don't think we really know. My personal thought had always been that vaping has, or most vaping has nicotine in it, and nicotine has effects directly on blood vessels, and so vaping probably has some degree of effect on things like vasospasm and things like that. But some of the effects of tobacco are in the lungs, and so, you know, if depending on how much of that vaping gets into the lungs would also determine how much of that causes atherosclerosis. I think we don't really know at this point, and my thought for a long time had been, oh, it's not going to cause the lung problems that smoking does, it's just going to cause the cardiovascular problems that smoking does. But as we all know from the news, you can have lots of lung problems from vaping, and so, you know, I think the jury's still out, but I try to tell all my patients to quit all of it. That's, I think, the safest option, but